Hello, my name is Lisa Thornsberry, and the topic of my discussion is development of a complex disposition unit. Discharging patients from the hospital is a complex process and has many challenges. Many of our patients often remain in the hospitals due to barriers to discharge or lack of suitable alternative settings that can provide the necessary care transition for our patients. There are many social factors that result in these barriers to discharge. In the United States, we discharge over 35 million patients each year. The Medicare population is a very high percentage of the patients that we care for. At least 20% of our Medicare patients are readmitted due to barriers to discharge and lack of appropriate care transitions. There are also penalties, financial penalties that CMS is placing on many of our healthcare facilities since 2013, and this is due to readmission rates. Vulnerable patients and families are attempting to navigate the transition from hospital to home, and they're likely to encounter a stressful situation and potentially adverse event and readmission when their care transition is unsuccessful. Many of these individuals have a lack of understanding or a lack of follow-up care post-discharge. Communication and input are necessary from multiple sources in order to have the best and appropriate discharge plan. Individuals involved in this, but not limited to, are the patient, family, case manager to include the social worker, the physician, any ancillary services, and then of course the insurer who plays a responsibility in placement of the patient. There are many evidence-based transitional care models that I reviewed for individualizing patient care at discharge. One of the things that I looked at in my review is interprofessional practice and interprofessional collaboration and the development of a unit and cohorting these patients. Multidisciplinary communication, according to the Joint Commission, and collaboration and coordination is key to any patient's successful discharge, and this must begin on admission. Problematic transitions occur in the healthcare setting today, but especially when the patients are leaving the hospital. So what I suggested is a priority of looking at these patients and promoting better care transitions, decreasing our length of stay, looking at our readmissions and decreasing those by developing a specialized unit within UK Healthcare. The Complex Disposition Unit, or I'll refer to the CDT unit, it consists of creating a single nursing unit and focusing on patients with barriers to discharge needs. Those individuals would also be transferred to this 23-bed unit and cohorted under the direction of a hospitalist who is already in place caring for these patients throughout the organization. The nurses, registered nurses, and the nursing care techs are already in place as well within this unit. So what we would do is we would take an existing medical surgical unit and turn this unit into a complex disposition unit. So these patients would be cared for by a hospitalist, like I said. We would add an advanced practice provider and a recreational therapist, because one of the things in discussing this with finance, it looks as if these patients could potentially be there around 50 to 55 days post-transfer. So optimization of the complex patient transitions would develop through this collaborative care model. This would be a central focus of UK Healthcare. The purpose of the CDU unit would be the cohorting of the patients, and they would go into a unit within Good Samaritan Hospital, which is a lower acuity hospital within UK Healthcare enterprise. Optimization of these complex patients for care transition would be created through a team working with these patients through collaborative efforts. These are patients who are medically ready for discharge, but they have existing barriers. These barriers could be lack of insurance, lack of Medicaid beds at a facility, psychiatric behaviors, patients in restraints. A lot of facilities will not take patients unless they're restraint-free. A new dialysis patient waiting on a chair. Sex offenders, guardianship. Patients who are waiting on guardianship can take up to 90 days in some cases. Or just an unknown disposition waiting on a long-term care bed. We also have IV drug use patients. We average about 20 to 25 in our organization, and these patients will stay with us for approximately 6 weeks. So this unit could cohort some of those patients as well, and they could start their rehabilitation process while they're there. So collaboration, including this interprofessional team, would make rounds on the patient daily and plan a goal setting and plan of care with their patients and families on a daily basis. So I did a SWOT analysis to look at the strengths, weaknesses, and opportunities and threats. The strengths is this is part of our hospital strategic plan, decreasing our length of stay, being patient-centered, and taking care of complex patients within our organization. Again, we have about 50 to 55 of these patients within our organization. Hospital medicine has already been established, and they would care for these patients. Finance preliminary studies show us that we would have a cost savings, which would be a great opportunity for our organization by having this unit. Our weaknesses is it's a new model of care, so it would be new to everyone involved, so we would need to get buy-in. We don't know what the outcomes of the patient is going to be, and we have limiting benchmark data. Opportunities would be leadership involvement, expected outcomes and what we would see, cost of care, and then getting approval for the 2 positions, which are roughly around $200,000. Threats, physician referral patterns. So we would have to get buy-in and trust from the other service lines in sending their patients to this unit. We would also have to market this unit and keep a census of 23 patients. And that would be a slow process over time. And then most important is employee engagement and employee satisfaction, because this would be a huge change for the nursing staff. Their patients now are there 5 to 6 days, and then they would be there for, around 50 days. So operational budget would only be the 2 positions that I would add of the APP and the RT. Capital budget, we would need to add a patient lift because some of these patients are bariatric patients, and this would roughly be around $6,700. The timeline, we would start after the holidays. The proposal would be submitted to leadership on February 1st. We would meet with different disciplines and leadership throughout the organization, order capital, post and hire the positions, go live, and then program evaluation by the end of the year to be completed. We would develop a dashboard for this area, and we would be transparent with our numbers and looking at the metrics. We would look at length of stay, readmission rates both internally and externally. We would look at our census. We would look at our cost savings as well. So one of the things that I think in summary is important is this is perfect for a DNP leader because this is a new and innovative way to collaboratively care for our patients in development of this unit. And I think a DNP leader would be perfect to do this and work with other disciplines in the care transition of our patients. Thank you.